Namaste. I JV'N Gaurav from the Faculty of Physiotherapy and Diagnostic in the Department of Diagnostic and Community Health in the discipline Radiology from JVWU Women's University. In today's session, we will discuss about the knee joint AP lateral view that is included in the course or subject Radiographic techniques of full body in BScRT second semester. Let me discuss about the knee joint AP view. It is a standard projection to assess knee joint, distal femur, proximal tibia, and fibula, and the patella. So these are the bones or structures that is visualized in the knee AP view. Okay. So this is the knee AP view. So the next is the indications for knee joint AP view or AP projection. This view demonstrates the distal femur and proximal tibia. Distal femur, proximal tibia or fibula in the natural anatomical position, allowing for assessment of suspected dislocation, fracture, localizing foreign bodies, and osteoarthritis. That is the inflammation in the joint. Inflammation in the joint. Localizing foreign body means if there any type of object or foreign body or any type of object is present, then it is the knee joint AP view is a useful projection to visualize dislocation, fracture, or presence of the foreign body or osteoarthritis. So the next point is the patient positioning. In the patient positioning, the patient is spine. Patient is in the sitting or lying on table, means in spine. On the table with the knee and ankle joint in contact with the table. Knee and ankle joint with contact with the table. Leg is extended. The leg fully extended and rotated slightly towards inward, so that the patella is centralized over the femur. Okay, so the patella is centralized. So leg is extended and knee and ankle is in contact with table, and so the knee is not rotated, but leg is extended and rotated slightly. Leg is extended and rotated slightly inward, so that the patella is centralized over the femur. Sandbag is placed over the tibia and the fibula to restrict movement and to visualize the knee joint properly. Next, the exposure factors or technical factors. The central point or centering point, the center of the knee AP projection, the center should be 1.5 cm distal to the apex of the patella. Okay. Collimations, superior to include the distal femur, inferior to include the proximal tibia or fibula, lateral to include the skin margin, medial to include the skin margin. So this is the collimation. Next is the orientation. The cassette orientation should be portrayed. Detector size 10 by 12 inches or 24 by 30 centimeter. Exposure factor for knee AP is in between the KVP 50 to 60 and the MES should be in the range of 4 to 8. SID, source to image receptor distance should be 100 centimeter. Grid, no, there is no grid used due to less radiation factor or less exposure factor is uses in this view. Okay, so the central ray should pass through the 1.5 centimeter below the lower border of patella at right angle to the film. Okay, or we can say the 1.5 distal to the centimeter distal to the apex of patella. Okay, appearance or image technical evaluation or a radiographic appearance, we can say the lower end of femur is clearly seen, but the patella is superimposed on the femur. Okay, upper end of the tibia and fibula are clearly seen, knee joint spaces and tibial spaces are seen very clearly. Means patella is not clearly seen in this view. Knee joint spaces, fibula, tibia, upper end are clearly visualized, and tibial spines are very clear in this view. Okay. So the image technical evaluation or radiographic appearance is a femoral and tibial condyles should be symmetrical. The head of the fibula is slightly superimposed with lateral tibial condyle. Means we can say that it is fibula is slightly superimposed. The patella is resting on the superior portion of the image superimposing the distal femur. Okay. The practical points. The fibula head is a great indication of a rotation. If the fibula head is entirely superimposed, the image is not AP. To correct this, one must internally rotate it until the knee is in even contact with the image detector. Okay. Very skilled patient may require slight caudal angle to better visualization. The joint spaces in the active position. The opposite applies for larger patients. Okay, so till now we have discussed about the knee AP projection. That is very much helpful to see the dislocation and type of fracture, foreign bodies, or osteoarthritis at knee joint, or it covers the distal end of femur, proximal end of tibia and fibula, and the patella or the spaces between the spaces of joint. Okay, you can see these structures in the knee AP position. Next one is the knee lateral position. Lateral knee projection or view is an orthogonal view of the AP view of the knee. The projection requires the patient to roll onto the side of their knee, that is affected side, and hence it is not an appropriate position trauma. In all suspected traumatic injury of knee, a horizontal beam lateral method should be utilized. Okay. The indications. This is often performed on bed-bound patients with suspected arthritis. It is an orthogonal view of the AP projection and demonstrates the joint spaces, yet sacrifice any assessment of the fluid level. So we can't assess the fluid level in the knee lateral projection. Okay, it is also not very useful for the patient that is severely injured. Okay, because knee is because the in this case the knee lateral is not possible. The patient positioning. The patient is lying on side of the interest with the knee of the interest closest to the table and other lower limb rolled anterior. Affect knee flex slightly across 30 degrees to the best of the patient ability. Technical factor. It is a mediolateral position centered point. The center of the knee joint, center to the knee joint 1.5 centimeter to 2 centimeter distal to the apex of the patella or at the tibial tuberosity. Tibial tuberosity. If the patella is affected by certain injury pattern. The collimation. It includes superiorly. It includes the distal femur, inferior to include the proximal tibia or fibula, anterior to include the skin margin, posterior to include the skin margin. The orientation should be landscape in case of knee lateral position. Detector size 14 by 17 inches. Exposure factor as like AP view 50 to 60 kVp or MES is in the range of 4 to 10 MES. SID 100 centimeter. Grid no. There is no grid used due to less exposure factors. Image technical evaluation or a radiographic appearance acute lateral position will have the following characteristics: superimposition of the medial and the lateral condyle of the distal femur, and open patellofemoral joint spacing, slight superimposition of the fibular head with the tibia. Practical point: it is easy to describe how a lateral knee should turn out. That is, everything should superimpose to achieve this can be technically done. Means uh, okay. So it is easy to get knee lateral projection. Okay. So patient in the patient position, the patient lies on affected side with knee slightly flexed, heel is slightly raised from the table, and the knee should be in contact with the film. The normal leg is brought over the affected normal leg is brought over the affected side, affected one, and should be resting on the table in front of it. Okay, sandbag must be placed over the leg. Appearance or a technical evaluation: lower end of femur separated from the other bones. Okay. So in this session we have discussed about the knee AP or lateral and lateral position. I think that is this session is very much useful when the patient comes with the complaint of pain in the knee joint or in cracking sound at knee joint and the difficulty of movement in the in case of injury, in case of any previous complaint or arthritic changes. So I think you all satisfied with this session. If you have any queries, then put it into the comment box. I will resolve it later. Thank you. The session is over. This session is powered by digital version 2.0, JVWU Women's University, Jaipur. Thank you.